Welcome everyone. Thank you for joining us today. We'll get started in just a few moments, but as you're joining, in the meantime, please write in the chat box who you are and where you're joining us from. And please also make sure that you select your language. To select a language, click on the bottom where you see the globe icon, and it will take you to the English or French channel. And then you can mute the original audio. We've also shared a few poll questions that we encourage you to respond to while we wait for others to join. If you'd like to read these questions in French, the French translation will be added to the chat box. And the questions are also on the slide in both English and French as well. As you'll note, the answer choices in the poll are in both English and French. If you're just joining us, please write in the chat box who you are and where you're joining us from. And please also make sure that you select your language. To select a language, click on the bottom where you see the globe icon, and it will take you to the English or French channel. You can then mute the original audio. You'll see on the slide here that we've also shared a few poll questions that we encourage you to respond to while we wait. These poll questions have been added to the chat in French, and they're on the slide in both English and French. Welcome everyone again to today's session. We're going to go ahead and get started. My name is Brittany Getch, and I'm a program officer on the Knowledge Success Project at Johns Hopkins Center for Communication Programs. Knowledge Success is excited to be partnering with FP 2030 on this series, and this is our 10th conversation in the Connecting Conversation series. If you've missed previous conversations, you can watch the recordings on FP 2030's YouTube channel or read blog post recaps that include recording links on the Knowledge Success site and get up to speed. This conversation will last for approximately an hour, and we'll have an open Q&A discussion with our three speakers. It's being simultaneously interpreted into French, as I mentioned, and it's being recorded in both English and French. The recording will be available in the coming days. I'd like to ask you again to please select your language at the bottom where you see the globe icon. Participants are muted throughout the duration of this conversation, but if you have questions for our speakers, please type them in the chat box as you follow along. My Knowledge Success and FP 2030 colleagues will be moderating the chat box and will get to as many questions as time allows. And just a little bit about this Connecting Conversations series in case you're joining us for the first time. Connecting Conversations is a series of discussions on adolescent and youth reproductive health, hosted by FP 2030 and Knowledge Success. Through the middle of this year, we'll be co-hosting these sessions every few weeks on a variety of topics. But this is not your traditional webinar series. We're using a more conversational style, we're encouraging open dialogue, and allowing plenty of time for questions. We guarantee you'll be coming back for more. The series has been divided into 5 themes. Our first one, which focused on a foundational understanding of adolescent development and health, started on July 15th and concluded on September 9th of last year. And our second one, which started on November 4th and concluded on December 16th of last year, focused on engaging critical influencers to improve young people's reproductive health. We're excited to begin this set of conversations with a discussion on shifting to an adolescent responsive approach in providing family planning and reproductive health services to young people. First, I'm pleased to introduce our moderator for today's session, Kate Lane. Kate Lane is FP 2030's Director for Adolescents and Youth, where she works closely with countries that have made adolescent-focused commitments to advance evidence-informed approaches to improve adolescent use of contraception. Kate also collaborates with FP 2030's Youth Engagement Manager to support the work of youth focal points and to strengthen the Secretariat's capacity for meaningful youth engagement. Kate has over 30 years of experience in adolescent sexual and reproductive health and has worked on both the implementation and donor side. So Kate, over to you.
Thanks, Brittany. And welcome everybody. Can you all hear me? Yes, okay. Welcome everybody to our third series of conversations. Just to remind you, this will be a series of 4 conversations over the next couple of months. Today is our first in the series, and we will have another conversation on March 18th, April 8th, and April 22nd. We're going to take a bit of a break between, we will not do a session on April 1st because that is Easter week and a lot of people take that time off. We do encourage everyone to take part in all of the conversations if you have time, because the conversations do build on each other, but if you can't make a session, they are recorded and made available on the Knowledge Success website. Also, just to let you all know, since the last time we had a conversation, we have transitioned from FP 2020 to FP 2030, and please do visit our new website for more information on how we are moving forward into the next 10 years. The focus of the 4 conversations we will be hosting over the next couple of months will be on how we can do a better job of ensuring the health services we provide to young people are of high quality and meet their specific and diverse needs. And we have a great panel of speakers this morning representing a very global perspective. We have Dr. Valentina Baltag, who is with the WHO, World Health Organization, and she's the unit head of the Adolescent and Young Adult Health Department of Maternal, Newborn, Child, and Adolescent Health and Aging. Valentina had a career in clinical practice and clinical research where she specialized in health systems management and public health issues in reproductive, maternal, and child and adolescent health before joining WHO. She's worked in several countries in economic transition in the WHO European region, including Central Asia, as well as in the WHO regional office in Europe. And currently she focuses on developing standards, policies, and strategies to strengthen government's response to achieve universal health coverage for the world's 1.2 billion adolescents, and provides technical support to member states in evidence-based planning of a multi-sectoral response for adolescent health. We also have Eva Berankite, who is the Liaison Officer for Sexual and Reproductive Health and Rights and Issues, including HIV and AIDS. Eva is with the International Federation of Medical Students Association, which is a global youth-led organization which represents 1.3 medical students around the world. She's worked in SRHR for the past 4 years on local, national, and international levels, and she has multiple expertise in advocacy, capacity building, project management, campaigning, and policy making in IFMSA's main focus areas for SRHR. She's also spoken on SRHR issues on a youth perspective in the World Health Summit in 2020 and was part of the IFMSA delegation to the virtual World Health Assembly. And finally, we have Dr. Maria del Carmen Calle del Vita, who is the Vice President of the International Association of Adolescent Health in the Latin America region. Dr. Maria Carmen is a pediatrician and a health specialist and holds a master's in government and health management with a doctorate in public health. She also has experience in operational, tactical, and managerial positions at the national and international level, and serves as president of the Peruvian Society of Adolescents and Youth, as well as the executive secretary of the Andean Health Organization, Hipólito, I'm going to mangle this, Unanue Agreement. She's also, and as I said, she's the vice president for the IAH, and a postgraduate professor at the Pontifical Catholic University of Peru. So a really interesting slate of panelists and some really, really great experience. So we're going to go ahead and dive into some our first questions. Oh, first of all, before we dive into questions, you all answered some poll questions as you came into the virtual session. So we're going to go ahead and put those poll questions up. The first question was that youth centers are the best way to provide services to young people because young people won't go to health facilities. 60% of you said that's true, 40% of you said that's false. That's actually false. They are not the best way to provide services to young people because we find that young people that do go to youth centers usually aren't there to access family planning services. And there's multiple reasons, lots of literature on why this is not necessarily the best approach to providing services to young people. The second question was the family planning needs of young mothers are often overlooked. Majority of you said that's true, and that is absolutely true. And looking at research, looking at DHS data, we find that young mothers who have just given birth are rarely are consulted or advised about using family planning to space their next pregnancy. And then finally, the last question here about providing training in youth-friendly services, the most effective way to create adolescent responsive health systems. 72% of you said true, 28% of you said false. I would lean towards the false as being the correct answer there. We know training in youth-friendly services is a really important approach to helping providers understand, but it's simply not enough. And there's a lot of research out there about needing things like supportive supervision and whole of clinic approaches. So training is a good first step, but that is just not the complete picture. So thanks for responding to those poll questions. And now we're going to go ahead and get into some of our questions. So the first question, we're going to start with kind of a couple of overarching questions. And the first question I'd like to pose to our panel is, why do you think a health systems approach is important for addressing the health needs of adolescents? First question. And then to back up that question, what are some of the most important features of an adolescent responsive health system? And I'd like to start with Valentina, because I know, Valentina, this has been really a focus of your work over the last couple of years, is really helping us understand why a systems approach is preferable in going forward. So over to you, Valentina.
Thank you, Kate. Very pleased to be here and talk about why the health system approach is important. Well, the short answer is because there is no other alternative. There is 1.2 billion adolescents worldwide, and in some countries, adolescents constitute up to a quarter of the population. And health system, or another way referred to as health sector, where the budget is where the most resources are. So we have to use those existing resources to serve better adolescents. We know that health expenditures tend to be disproportionately skewed toward adults and elderly. And across countries, health spending on children and adolescents, if we take the age break from children from 5 on to the end of the second decade of life, 19 years old, then this proportion is from 7 to 8% of the total health spending, despite this group accounting for up to 20% of the population. So there is a disconnect between the healthcare needs to be addressed by existing services and what is being spent on adolescents. Now, one might say that, okay, but they are healthy. But here is the problem, that we know that adolescents have unmet healthcare needs, and then there are services and conditions that are very sensitive to the timely healthcare provision. For example, addressing mental health in a timely manner, sexual and reproductive health, nutrition, communicable diseases, immunization. So those are the services, the type of care that is important to be delivered within the existing resources. So the short answer, there is no alternative. It is the only form of sustainable and scaled universal approach to the health of adolescents.
Thanks, Valentina. I can't say that I disagree with anything that you've said. Dr. Maria Carmen, I think in some respects, Latin America has been tackling this issue of adolescent health services a bit longer than some of our colleagues in Africa and Asia. Maybe you could give us some insights as to how Latin America has been trying to be more systematic in their approach, and some of the lessons learned that have come out of countries, for example, like Chile and Uruguay, which I understand have done a lot of work around scaling.
Hello, thank you very much for this invitation. I would like to talk about what is happening in Latin America. You know, Latin America is a region of much inequities. We're talking about people that are very different in our countries and inside our countries. So there are two alternatives now. We have the friendly services, and we have the another approach that is to have people and health providers with capacities to be with the young people. But that's not enough. When we talk about adolescent health, we are not talking only about services. We have to talk about social determinants. We have to talk about education. We have to talk about possibilities, because all the people that have some kind of relation with adolescents, we want they to have skills, to have knowledge, but first of all, to have opportunities. So when we talk about adolescent health, it's not just services. And I think that that's the first message. The second message is that the budget is for children from 0 to 5 years in our countries. There are the gaps are very huge between the budgets from 0 to 5 years and from 5 years to 19 years. And we cannot do nothing if we don't have budgets for them. I think that we have to shift from the 1,000 first day to the 1,000 first weeks. And it's important to be very, very clear that adolescents are not having the best health, because 40% of the mental issues are going to begin in adolescence. 70% of the habits that will lead them to ENT, to non-communicable disease, are going to be in the adolescence. So when we talk about adolescence, the first thing I want to tell is that we have to be clear that they have rights, and the health providers have to know exactly that they have rights. If we don't have, and I am not just talking about reproductive and sexual rights, I am talking of human rights. Okay.
That's a really good point, Maria. And whether we often just assume that adolescence is the healthiest time of life, and we're increasingly seeing that many of the behaviors that young people are adopting in adolescence ripple across the life course and even into the next generation. Eva, I'd love to hear your perspective as a medical student, as you are about to embark on your career as a medical doctor, and how you think where do you see the field going, and how can medical students really contribute to changing the way we see adolescents within the health system?
Of course. Well, first of all, I think we do have to start with ourselves as medical students, because even though our knowledge is so reliant on the medical schools we attend, we also can seek out informal education. We can join non-governmental organizations, as I've done personally, and actually gain the knowledge that is lacking in our curricula. Additionally, I think medical students could work more in their advocacy efforts, especially on a national level or a local level, just to sort of enforce for medical schools to actually address the adolescent needs or include it in the curricula. Because I come from Lithuania, so a small Eastern European country, and I would dare say that our schools do not address the needs enough. I only have one cycle on children and adolescents, and everything else is focused on adults. And additionally, everything is kind of focused on a very paternalistic approach. So we are not encouraged to speak to our patients equally. We are encouraged to make decisions for them, which I think is just going backwards.
Great. You know, one of the things that I've noticed over the years is, you know, the adolescent population isn't getting any smaller. So if we are really serious about serving the needs of young people, we really have to take more of a systems approach. And I'd like Valentina to weigh in a little bit on what are some of the elements of a responsive systems approach.
Yes, thank you, Kate. No, I think it is important. We articulated why it is important to take this approach, but what do we mean actually by adolescent responsive health systems? So it's very important to understand that adolescent responsive health services is just one element of a health system approach. Very important element, no doubt about it. But it is like a good engine. It works only when all its elements work well. Then what are the other elements of a health system? And here we are talking about the key functions of a health system. One is the governance. So a health system approach would mean that there is someone in the Ministry of Health and in other key sectors and ministries that has these adolescent health lenses in mind when decisions are made. So governance is adolescent responsive and sensitive to adolescent needs. Then the second function is financing, how resources are being distributed. Here are several elements within it, but what are the budgets? And also, as part of it, how are providers are being paid? Where are the incentives for healthcare providers to provide the services the way that we need them to be for adolescents? That's the second element. Then health management and information system. This is the third element of a system. An adolescent responsive health system would be a system that knows its numbers with regard to adolescents. Because if we do not know what are the key issues, where are the gaps in service utilization, in service use, in the quality of care, we cannot address the problems. The problem that is not visible does not exist. And then adolescent competent providers, that's the fourth element of adolescent responsive health systems. And I'm not listing them in any order of importance. They are all equally important. So how healthcare providers are being trained? What are the competencies that they are being asked to have while dealing with an adolescent client? That's another element. And of course, service delivery. And here we can talk more about what are the service delivery models that are suitable to address the needs of the majority of adolescents, but also what are the models that may enable us to reach those underserved that will not come routinely to the mainstream networks of facilities. So this is what a health systems approach means. When all those 5 elements have adolescent health lenses and work together. Again, adolescent responsive health services is the central part of it because this is where the interaction between the adolescent and the provider happens. But if the other elements are not there, then the provider simply is not supported to fulfill the mandate. Over.
Thank you. And I wanted to circle back to what Maria Carmen said earlier about not just the health system that we need to improve, but we also need to look at improving the overall system in which young people develop. Community education, and unfortunately many of these sectors don't speak well to each other, and they're very disconnected. And I think we need to continue to find ways to help health, work with education, work with civic participation, and making sure young people have an overall support for a lot of the choices and decisions. And since we know from, for example, the Lancet Commission is a lot of the drivers of adolescent health occur outside the health sector. So we need to be looking at those other factors as well. I want to move on to the next question. Is a few countries seem to have been successful in implementing more systems-focused thinking to improve the quality of services that are provided to young people. And what are some of the things do you think has made it possible for countries to apply this more comprehensive thinking? And have these countries seen better health outcomes among their adolescent populations? And I wanted to also just drop in a point there about, I think the issue about budget is incredibly important. And as EPI 2030, we spend a lot of time advocating for line items and budgets for purchases of contraceptive commodities. And I'm increasingly pushing the notion that we need to also advocate for budget line items for adolescent programming and services. So anyway, let's posing that question. What are some of the successes that we've seen in other countries, and what has contributed to those successes? So I'm going to start with Maria Carmen again.
Well, in Latin America, we can talk about Chile, and we can talk about Uruguay, and maybe Colombia and Peru, maybe. I'm not completely sure about it. And the reason is that there was a political decision, no? That's very important. But when we talk about the budgets, we're talking about political decision. If the top persons decide that adolescent health is very important, they are going to have money there. So that's the first thing. The second thing is, I think that we have to talk about universal interventions. We have to talk about adolescent-focused interventions, and we have to talk about interventions that are for adolescents with some kind of vulnerability, no? So there are three types of interventions. And that's why it's not just the health system. We're talking about the education ministry. We're talking about the security ministry, because one of the mortalities in Latin America is violence and homicides. So we have to talk about that also. I think that the providers' preparation is very important, but I think that we have to go out of the box. We have to know not just clinical issues. We have to know about laws. We have to know about what is the Rights Children's Committee saying. You know, we have the 25 general observation, maybe 1 week ago, I don't remember. And they are talking about networks. They are talking about all the other alternative forms of giving health services. And the providers have to have those skills. And I think that one of the issues that was very important for these better services were the providers' skills, because we have to be very clear. The providers are beside the adolescents. They are not going to decide. They have to be beside so they can give some kind of guidelines, because we have to be very respectful. The adolescents have desires. The adolescents have needs. And what the adolescent says, I would like you to go to the handbook of Oxford and about all the research. No, it was, I think one of the editors was Prerna Banati. And one Peruvian adolescent only asked for three things. We want a secure country. We want a predictable country, but we want an equity. We want equity. So I think that we have to work on those things, not just like Valentina says, health services are where we have the touch, no, with the encounter with the adolescents. But if we don't have solutions for the other things, we're not talking of nothing. And I think that it's very important education and sexual education and many. I'm very clear. Adolescents have to have knowledge, have to have skills, and have to have opportunities. I think that there are the three things we have to bring to the adolescents. But we have to be respectful. We have to be the confidentiality, not judging them. And that is very important in our countries. We have this we are adults and we are better and we know how to do the things. No, that's not these adolescents are a beautiful period now because they have much knowledge. They have very much information, but the problems is that we have to be beside them because the emotions and the mental health is not so good. So, and now I would like to have 30 seconds about the pandemics. Now we can't talk about these things if we don't talk about COVID, the pandemics.
Mm-hmm.
The pandemics are changing our lives, no? And so we have to be very, very innovative, creative, no? To think, how are we going to approach them? Because things are changing. And as we talk in Zoom or in, I don't know what kind of platform is this, that's the way now. We have to talk with them in this way.
Yeah,
because we are going to be near them.
Yeah, we can't ignore the impact of the COVID pandemic.
Yes,
and we worked with IAH last year to put out a statement about the importance of considering the needs of adolescents, and they are definitely being overlooked in many cases. I wanted to come back to Eva briefly. I'm not sure where you're planning on going when you finish medical school, if you're going into private practice, if you're going to work in the public sector, but I think a really good point is, you know, oftentimes we focus a lot on the health systems or youth-friendly services in the public sector. How do we do a better job of engaging the private sector? Because we often hear young people like to go to the private sector because they feel that the quality of care is better. But how do we help our private sector colleagues think through how to do a better job of providing more responsive services to young people?
Well, I think the first thought that comes to mind when it comes to the private sector and youth, perhaps, is in terms of accessibility itself, because I feel like, well, first of all, youth, adolescents, they do not have their own financial means, let's say. And the private sector, at least in my experience, is oftentimes very expensive. So I would say that there would need to be a more systematic approach of how to make it more accessible to the youth itself, perhaps address the vulnerable populations a bit more. Would this become another public sector? I do not know, but I do feel like this could be addressed in this way.
Great. Okay. We're going to go ahead. We're getting a lot of questions from the chat box, so we're going to go ahead and go to starting to answer some of the questions that we're getting from our colleagues around the world. I'm going to start with a question from Africa. One of the participants is saying that we are seeing in Africa the formation of adolescent health spaces within health facilities, which provide health information, especially in reproductive health. And some people call these youth corners or specialized youth-friendly services. And I think I'd like to get the panelists to comment a little bit about this notion of youth spaces or youth corners. And is that approach, in your opinion, the best approach, or should we be looking at other ways of providing services to young people, improving the quality of care and strengthening systems? So let's start with, well, let's go back to Eva again. if you don't mind.
Just a second. I feel like I'm having a bit of technical difficulties.
Okay.
So
Okay, sure. Valentina. Yeah, why don't we start with you, Valentina?
Yeah, thank you. No, I think as a complementary approach, it is a good approach. The details, the evil is in the details, so we would need to know more about, what are the results and what are the objectives for those use corners. But why I say it is a complementary approach? Because if their mandate is mainly information provision, we know that just information provision does not work. You achieve results when you combine information provision with accessible services being provided on site. So if those use corners are intended to complementing the service provision by a trained healthcare provider, then an additional place where adolescents and youth can access information, that's good. But if it is not linked with a quality healthcare service provision, then you might need to look into it. Also, what we know is, and I'm back to the question that Kate asked previously, what has made it possible for countries to apply this more comprehensive thinking? And one of the elements that made it possible is the critical thinking and the ability to change the paradigm when necessary. Critical thinking in this context means evaluate, evaluate, evaluate. Every use corner around the world was established with very good intention and with some assumptions in mind. Now, after evaluating, after many years of operating, and when the evaluations have started to come up with the result, we saw that some of those intentions did not realize in practice. So therefore, whatever initiative you put in place, whatever form of service provision, evaluate it to see if what you intended to achieve, you did achieve by this. Because we know, for example, when an evaluation came up, which was based on the results of 22 studies in many countries on youth centers, the intention was to serve every youth, male, females, younger, older, but in practice what has happened that only older male were accessing those services because of the associated stigma. So this consideration about is the use of sexual and reproductive health services still stigmatized in a particular country or in a particular context? It might also give you some answers on what is the best way to provide those services so this stigma does not become a barrier. Thank you. Over.
Good point. Thanks, Valentina. And and also in addition to evaluation, I think, we need to do a better job of looking at the data that's available to us. And I think sometimes we may go on our gut about what we think is the best approach, but it's not necessarily reflective of what the data is actually telling us. And so we need to do a better job of looking at that data or finding ways to collect data that's not available. And I think, many of us for many years have been advocating for age and sex disaggregated data so we can do a better job of identifying where the challenges are. I wanted to move on to another question from the chat box, and maybe we can pose this one to Maria Carmen. In India, for example, one of the biggest challenges is ensuring this interministerial convergence and action, trying to get health and education and women and child development, all these different sectors working together, and sometimes things just kind of come to a standstill. And I'm wondering, based on some of the work in Latin America, where a few countries have been able to take a more systematic approach, have you seen any of this kind of interministerial collaboration? And if so, what have been some of the things that have facilitated that kind of interministerial collaboration?
Okay, I can talk about the Peruvian multi-sectoral commission for prevention of teenage pregnancy. We were one of the founders of this commission. It began in 2013. It's going to end now this year. And the thing is very clear. If we have leadership, if we have the month meeting, if we have clear objectives, and if we have evaluation, everything goes okay. But what's the problem? The problem is that we have much changes in our ministries. For example, in Peru, in the last 2-3 years, we have had, I don't know, maybe 7 ministries of health. And when there are many changes and the policy is not very in the persons, we have to have changes. And the other thing is, yes, we can articulate in the ministers, but we have to be very clear about 2 things: the objectives and the budget. Because if we have the objectives, but we don't have the budgets, we can't have rights without budgets. It's very clear for us in Peru. We can't have rights, and I am talking about human rights, without budget. Because when we began talking about this issue of teen pregnancy, if you see the numbers, and maybe in the 20 years, in 2 decades, we have not had any shift. We are in the same numbers, maybe one minus one, no, but we are in the same numbers. And it's impossible to articulate if we don't have changes in social determinants. I can say, yes, everybody is going to have a secondary education, and everybody goes to the school, but it's not just that. We have to be clear that we have to give a quality education, and we have to be with everybody. There are many experiences in our countries, many multi-sectoral committees, where there is not just health and education. There are all the sectors, but they are not very, we don't have much progress in that. I'm saying the truth.
Mm-hmm.
We don't have much progress. But I think that we have to begin in an area. For example, no? If we have a multi-sectoral commission, let's highlight one of our regions, just one of our regions, because Peru is very, very different from region to region. Let's talk about this region, and let's put our effort in this region, so we see some kind of progress. But it's very, very difficult, because we have a huge amount of people that are prepared, that have the knowledge, the importance of adolescent health. In Peru,
Yeah.
in America, we have very good people there, but it's not enough.
Yeah.
We have to do much advocacy, but a constant advocacy, because sometimes we have presidents that are interested in adolescent health. And
yeah, the advocacy is never finished. You know, they're constantly.
Never. The people think that, okay, let's talk with him, it's okay. No, it's not okay. We have to work.
And that's our challenge around sustainability.
Is the course of life. We don't have to go to the adolescence just at 10 years. We have to think about this decade, that it's
more of a life course approach. I wanted to ask Valentina, I think, you know, one of the, I think we've all been asking for multi-sectoral approaches, at least since I've been working, and that's been 30 years. We've been pushing this notion of multi-sectoral approaches, but one of the most natural collaborations, I think, is between education and health. And I think Valentina can talk a little bit about a new initiative around health promoting education systems and this kind of intersectoral collaboration.
Yes, thank you, colleagues. I think we asked from the health sector, it's not new for us that education is such an important determinant of health, and we have been working with the education sector for many years on various initiatives, generally labeled as health promoting schools initiative or school health programs. They have a history of 20 plus years in many countries. Now, the problem was and still is that those initiatives were primarily led by the ministries of health because we had the data. So we felt that our solution should be there with the education sector. Now, what has happened that health became, or those health-related, health-promoting projects were like bolted in the busy schools, what they do routinely. So now we are changing the paradigm, and we launched last year a new initiative together with our UNESCO colleagues, but also with other UN agencies, which is called Make Every School a Health Promoting School. Now, what is the change in this initiative? We are saying boldly that this should be led by the Ministry of Education, unless it becomes part of what the education is busy with day to day. It will not work. It won't be sustainable. So it is the same approach, the system approach, but now to the education. So the health promoting education systems, this is what we need. It means that schools should have health and well-being as a primary consideration in everything they do. Curriculum, school ethos, school culture, school infrastructure, the way they work with parents and communities. Health, well-being, and education are equally important, and schools, being institutions that are paid by tax contributions from the population, they should contribute to the health and well-being. I always had problems when one would say we should frame it in terms of absenteeism, and I was thinking, since when well-being and health is less important than absenteeism? So this is where coming now with global standards for health promoting schools. We are saying this should be led by the education sector, by all means, with all the support from health and other important ministries. So we hope, without going details in this call, look for it. It will come out end this spring. And we will be there to support those interministerial, intergovernmental initiatives towards implementation.
That's a great thing to hear, Valentina, because my observation over the years has certainly been that there's a huge disconnect between school health programs and what the Ministry of Health is doing. And they often they don't talk to each other well. And I've actually seen in some countries where they hire school nurses that are employees of the Ministry of Education, but then they have absolutely no oversight or support from the Ministry of Health. So to get these two sectors talking together, I think is really important. I wanted to go back to Eva to talk a little bit about sort of the kind of education and training that medical students are getting in your own experience, and what you think might be changing or what you think some of the gaps are. And I'd particularly like you to touch perhaps a little bit on mental health, because this is really emerging as a huge concern for young people, especially within the context of COVID, right? We're all just frayed mentally, but I think especially young people. And we know that mental health issues often emerge during adolescence. So how well do you think the pre-service training is supporting medical students to be really ready to respond and to the needs of young people, and are some things that we should be advocating for with the pre-service institutions?
Thank you. Well, when it comes to mental health, and especially how medical students are being prepared to actually deal with any sort of consequences, well, in my personal experience, and perhaps a lot of experiences of medical students worldwide, the approach is not enough. So that's probably the main conclusion of it, just because a lot of the curricula focuses on somatic diseases. We check for clinical symptoms. We just physically look at the patient, and there's a lot of paperwork additionally involved. I'm moving on to sort of the health system part, because the doctor in my country especially, they work on both examining the patient and filling just a bunch of papers, which is oftentimes half or more than half the work. This is what I've seen so much. And even though we may see that the patient is struggling or stressing or having mental health problems, the best thing we can do for now is just refer them to someone who's a specialist. And oftentimes it's not even done because the professionals that are currently working were not trained as well. So the medical students that are my age, the medical students that are young, I've mentioned this a little bit, we just seek out additional curricula, additional activities that will teach us to recognize sort of the stress or how to communicate with patients better. But those are the gaps that I would identify.
Yeah, invite Valentina or Marie Carmen to weigh on that as well.
Yes, thank you. It's a very important question. And, you know, unlike maternal and newborn health care, where there is a specialist workforce, obstetricians, midwife, or in child health care, for example, trained pediatrician, trained GPs. So those, they are receiving very specialized training in relation to pregnancy, postpartum period, antenatal care, and in relation to pediatrics. But in almost every country in the world, adolescent health training is not part of the formative years of the medical workforce. And even very often, continuous professional education opportunities do not exist in adolescent health care. So there is a huge lack in professional leadership for adolescent health care, and that poses a very big problem. There is also a paradox that over the last 2 decades, let's say, the age of pediatrics has increased in many countries. For example, in Tanzania, 2 decades ago, the upper age limit for which a pediatrician will care of the population was increased by 8 years. It used to be 11 years old, so that was the cutoff after which the child will be then taken care of by an adult physician, and today is at 13.2 years. It's probably different in different districts. So it has increased by 8 years old. Now the assumption, that's just one example, but there are many examples how this age of pediatrics have increased in countries. But so the assumption is that pediatricians would take care of adolescents, increasingly older adolescents, right? But then the paradox is that they did not receive any training. So any changes in how the workforce is being trained have been made. So professionals were put in a situation that they have a very distinct period of life, very distinct population to take care of without any training. So that's a huge issue. And that's, again, part of a system approach. We cannot have sufficient funds to train in service, basically to retrain the workforce. So we have to invest in what is being taught in medical colleges, in medical universities, in nursing colleges. So there, the core competencies are already part of the curriculum. Of course, it does not replace a lifelong learning, but unless you put this component in the formative year of a professional, then it's very difficult to convince someone who is a 50 years old nurse, never heard about developmental stages of adolescent, that this is really an important issue. Over.
Totally agree with you on that. Maria, I'm wondering if, for example, in the United States, I think we're increasingly seeing adolescent health as as an important subspecialty. But still, we don't have a lot of adolescent medicine practitioners. Is adolescent health part of the training curriculum in some of the medical institutions in Latin America?
Well, in Latin America, when we compare the medical curriculum and the nurseries, the midwives, the psychologists, they have more of adolescent health in the non-medical curriculum. That's the reality. When you go and you ask for the courses of the nurses, of the obstetricians, of the psychologists, of the nutritionists, they have more of adolescents that us as medical students. Okay. The second thing, we in the pediatrics formations, adolescence is like a week, maybe, no more. And we have been working so much with the universities to have more time for the adolescents, but we don't have many success in that. Okay.
Yeah.
But I think that we have to work for including adolescents' health in the pre-grade, not the post-grade. Post-grade is a little bit, it's not early. It's many delight, no? So we're working in that. We're working to have adolescents in the but something I would like to say is that we have to change our approach about medical grades. It's not just physics, it's just not, mental health is so important. And mental health, we must have knowledge in all the professions, not just the medical people, because now we have how to give treatment in many medical issues that in 20 or 30 years ago we couldn't do nothing. And one of the things is to have an early diagnosis and to initiate the therapy correspondent rapidly. So mental health now is very important. We know that 40% of the mental issues begin in adolescence. And we know in many studies of a life course, that, for example, adolescent boys in early adolescence, if they have some kind of crisis, they are going to have a lifespan that will be not the best one. So we have to think about this approach of course life. So the pediatricians, I am a pediatrician, the pediatricians have to attend adolescent people. They have to, because they know these girls and boys from when they were newborns.
Right.
And we want to talk with them. I will repeat, we have to be beside. No, we have to be near, but not making the decisions for the adolescents. So I think we have to do much. We have to.
Yeah, a lot of work ahead of us.
Yes.
But we have a lot of advocates out there. And I was just remembering back to when my daughter was pregnant with my first child and was going through the birthing classes. And I told the pediatrician there what I did for a living working with adolescents. And he his eyes got really big and he goes, yeah, I see more adolescents coming into my clinic and I don't know what to say to them. And this was, in a high income country. So yeah, we need to be doing a better job of preparing our providers. And I think Valentina has some ideas or some suggestions about where this has been done in other countries. I also just let folks know we are coming up on time. If you're willing to stay with us for another couple of minutes, we'll let Valentina answer that question and then we'll go ahead and wrap up the session. So Valentina, you wanted to give us some suggestions?
Yes, no, thank you. I just wanted to give examples that this is happening in countries. So participants in this call feel empowered. We are not only talking that, yeah, this is something that would be good to have, but tremendous progress was made. For example, in Uganda, after some exposure and a master training in adolescent health, then the postgraduate training has increased. And now a 6-week standalone course on adolescent health is available for second-year residents who are doing their master's degree in pediatrics and child health. And also, after doing this for postgraduate training, Uganda is making efforts now to introduce an adolescent health component in pre-service training in the Bachelor of Medicine and Surgery program. Another example from Ethiopia. Since Ethiopia since we trained the faculty staff of the Haramaya University, then there was an attempt, so the curriculum was developed for Bachelor in Public Health and Adolescent and Youth Health and Development. There are other countries and examples from India, for example. As we speak, India, which Medical Council in 2019 has recommended that adolescent health and development is taught in pre-service training in a MBBS program. So now a team is working to develop a curriculum that includes adolescent health across 4 disciplines: psychology, community medicine, pediatrics, and psychiatry. So I'm bringing those examples just for the benefit of participants in this call, that we are not talking about something that is theoretical, but within the last 5 years, many countries have made this step and are working to increase this component, or made it available from scratch in the pre-service and postgraduate training. over.
And I think WHO did an assessment a couple of years ago around pre-service training in Asia, some of the countries in Asia. So yeah, you're right. It's important to note that this is not, we're not starting from scratch here, that we have a lot of great opportunities or examples to build upon. And I'm going to go ahead and give Aeva the last word here as our future, you know, as she's stepping into the future and is carrying the torch forward. What are some of the things, Aeva, that you think that we should be focusing on to really just try to advance this notion of systems, you know, stepping beyond youth centers and youth corners to be more systematic in our approach to young people?
First of all, this is a thing I will perhaps never get tired of saying, so that's giving leadership to young people, giving leadership to adolescents, because so often we have older generations just speaking on behalf of adolescents, what they need, what their specific needs are. Instead, let's ask them how they feel. Let's provide a safe space and they will give us all the answers. Let's just let them speak. So perhaps this is the main message that I am carrying into this panel. And it was lovely hearing from Dr. Valentina and Dr. Maria.
Thank you so much. Any final thoughts, Dr. Maria? Do you have any final thoughts or words of wisdom?
Yes, I will say that, yes, there are progress. I'm not going to be negative. There are progress. And if you go to Latin America, many progress. But we have to be real. These are different adolescents. We are in part in our history that is different. And I think that we have to listen them.
Mm-hmm.
We have to listen them. It's not just about how the measures, how the standards, that's okay. But the real people that know about this are the adolescents. And we have to be clear that there are very kinds of adolescents. There is not just one form of making things. There are the poor adolescents. There are the adolescents that have chronic diseases. There are the LGBT. There are the adolescents. There are many kinds of adolescents. So I would ask for personalized attention. This is not like saying, now we are going to do this first step, second step. No, no, no. We have to, and you know, we can't be friends. That's another issue. Yes, I am the provider and he is my buddy. He is my friend. She is my buddy. She is my friend. That's not the idea. We are health providers. And just two things: confidentiality, that I think that is very difficult in the networks, because you are hearing me and many people is hearing me. So when you do a telemedicine, with the networks, we're not very sure about the confidentiality. But most important of that, not judging. If an adolescent comes, you are not judging. You just have to attend them and be beside them. That's the idea. That's the idea.
And I think thank you. And just my own observation over the years is, you know, young people don't really want anything that much different from what adults want. They want to be treated with respect. They want to have confidential services. They want to get in and out quickly and not have to sit for hours in the waiting room. They don't want to have to pay a lot of money for their services. So, you know, we have to stop seeing young people as this different category of special needs and recognize we can do a better job in our overall system. Certainly with first-time mothers, young moms who are coming into the health system for the first time, we have to recognize that not only are they young moms, but they're adolescents, and we need to apply some of what we've learned for youth-friendly services to these young moms. So some of the things that we've have been raised in this session this morning, we'll be addressing in future sessions. The next session will be March 18th, the next conversation, and we'll be talking in the coming weeks around different models of care, different segmentation of young people, understanding that, young people are not all a homogeneous block. One size does not fit all. So again, thank you so much to Valentina, to Maria Carmen, to Yeva for, joining us this morning. I feel like we could have gone on for another hour or so, but we want to be respectful of your time. And please do join us again in 2 weeks when we are talking about how services can better meet the diverse needs of young people. And enjoy the rest of your day. Again, thanks so much, and we'll see you in 2 weeks.
Bye.
Thank you. Thank you.
Thanks.
Thank you. Bye-bye.
Goodbye.
Bye.